All right, guys, today we will be talking about some pearls when it comes to pulmonary embolisms. One of the most important things when it comes to your patient, you want to immediately stratify them into massive, submassive, and low risk for pulmonary embolism. The way you do this is by looking at vital signs. If their vital signs are unstable, they are automatically a massive PE. A submassive is going to be no shock, but with right ventricle dysfunction. So when we talk about this, we're thinking push the heart rate up, but they're still perfusing. And low risk, we'll talk a little bit more. So one of the things I learned recently is that hemodynamically unstable pulmonary embolism patients, they're candidates for treatment with IV TPA. And the reason this was kind of surprising to me is on board questions, at least for step 1 and step 2, they usually stop right at heparin. So, identifying PEs and then giving heparin. But once you start getting into more of the ABIM concepts, more of the higher level concepts, you definitely want to think about putting TPA on board. Now, like I was saying, if they're hemodynamically stable, and typically on questions, but also in real life, if their heart rate is higher than their blood pressure, that is someone that's unstable. And so for hemodynamically stable, then Lovenox is given in all cases except for renal failure. And then you start warfarin or a DOAC at the same time. So really knowing these three things will get you pretty far. If a person is hemodynamically unstable and they have contraindications to TPA, this is when you're going for that surgical embolectomy. And if a person has contraindications to anticoagulation, you want to go for the IVC filters. So obviously this isn't really something you memorize, but some of the contraindications to TPA are similar to those for stroke. So really one of the big ones is an active bleed or a recent stroke. Active bleed or a recent stroke, that's about it. Now, when you're thinking about someone with a risk for thromboembolism, do they need Lovenox? One of the trials I learned about recently was the ADOPT trial, so I won't really get into all the nitty-gritty of the trial, but essentially, Eliquis was not worse than Lovenox. That's really the big idea. Now, one thing I thought we could try
is I wanted to just go through this article on pulmonary embolism with you guys because this is a little easier than trying to make my own slides.
This right here is the table talking about risk factors for venous thromboembolism, and really it's all the stuff but I want to bring your attention to the fact that pregnancy and the postpartum period, that's definitely one of them. And when it comes to factor V laden, if the patient's parents have also had a PE, that's when you want to start thinking about this. Cancer, for sure. So yeah, that's about it. It's a pretty long list, not really worth memorizing, but just know that you can come back to this list. So really, one of the things I wanted to show you guys was the Wells criteria for predicting whether someone has a PE. And one thing you'll see on here is that fever is not on here. So you can't rely on someone. If you think someone has a pulmonary embolism and they don't have a fever, that does not rule it out. So things you want to think about, if they've ever had a DVT before, keep PE on your differential. If they've had surgery in the past 4 weeks, or this is something, especially nowadays when people get sick a little more often with COVID, one thing you want to think about is they may not have had surgery, but let's say they were feeling lousy with COVID and are just laying in bed all day. So, that could be immobilization comparable to a minor procedure. Obviously, DVT symptoms. And so one thing I want to show you is, let's say someone's being treated, like I'm currently on my hem-onc rotation. Let's say someone is being treated for cancer and also just has been feeling lousy in bed for a few weeks. You're already at a 2. So you're already thinking about a moderate pretest probability for PE. The original Geneva criteria, that has a little more of the lab values, so I know some people like this a bit better. As far as clinical suspicion of PE and the workup to do about it, I think there's really two key takeaways. One, I know a lot of people in this day and age, they consider a D-dimer largely useless, especially because frequently positive in obese patients. So I don't have the exact stat pulled up, but a good rule of thumb is that literally no one with a VQ scan that's negative has a pulmonary embolism. It like a normal VQ scan essentially rules out PE. That is very high yield. The rest of this you can kind of work your way through. And this is kind of talking about what I was getting to earlier, is that if someone is hemodynamically unstable, you consider thrombolytics or surgery. These people could die within an hour, like literally. And then there's a lot of stuff about prevention. It's hard to really get a good number out of cardiologists as far as how long someone needs to be on anticoagulation after a PE. It really depends on if the PE was provoked or not. That's really a big thing. So if someone had an unprovoked PE, there are times when they're on lifelong anticoagulation. If you have a good reason for the PE, then you can have them on about 3 months. But that really varies, so check with your institution. So that was about it for me. Hopefully you guys found this video helpful. Thank you guys.